Who do we have?
Emma, I'm from Victoria.
Emma. Greetings, Emma. What year are you?
Second.
Excellent. Well, you're braver than everybody else.
Yeah, someone to me.
So what we've got here, we've got a 52-year-old male who's a bit overweight, and he's got a fasting blood glucose of 6.9, which is probably below the diagnostic threshold for diabetes. He has a standard Australian diet, which should tell you a lot, and is a bit plump around the middle, and he's got mild hypertension. So I guess, I might open the floor to you about what your thoughts are on this stem and how you would initially like to approach it.
Well, I guess my initial approach would be probably taking a bit more of a history. It sounds like examination's been sort of somewhat done. But I guess in terms of history, trying to work out a little bit more about whether he has any medical conditions that have caused him to be this way, whether to be overweight, whether he's got any other medications, whether his hypertension's been treated, or whether he's seen a dietitian previously to try and manage that with diet, whether he's had sort of regular blood tests which point to other cardiovascular risk factors. And then probably just exploring a little bit more about his diet and his exercise habits, his sedentary behaviours, his job, whether he's always been overweight or whether this is something that's sort of come on with age or a particular change in lifestyle. But we're going to start.
So probably like most males, he's probably quite inattentive to his health, and you can probably assume that this is a primary presentation. But he does have a few old blood tests. What blood test in particular would you like to look at for cardiovascular risk?
Well, probably fasting lipid studies, an HbA1c as well. And then, are you asking if I just had one, or if can I have a lot?
You can have as many as you like. It would be nice if you would limit it to the ones that you would personally find most useful and feel the most comfortable chatting about.
Fair enough. I'd probably also want LFTs, seeing whether he has any sort of fatty liver type picture, kidney function and FBA as well. I think if he had hypertension, he's of an age and a sort of a risk profile where it's probably secondary hypertension, but potentially if it was new and hadn't been investigated, like at least a kidney function, if not primary hypertension, but otherwise a screen for that. And those would be the main ones I would start with as sort of a primary look. And obviously, if there was like risk factors that came up in the history, could think about things like thyroid or hormone function, depending on what we thought was the cause.
Okay, well, you've got some excellent things there. So I guess with fasting lipids, so I probably won't put you on the spot with that one, but I will make the point that when it comes to assessing cardiovascular risk with a lipid panel, there's a metric called the triglyceride to HDL ratio, which is far superior to other metrics. When we're looking at absolute level of cholesterol or absolute level of LDL, the triglyceride to HDL ratio is a far superior metric in the assessment of what we call atherogenic dyslipidemia, which is basically saying, is somebody likely to have a heart attack based on this lipid profile? So again, you saw what I talked about earlier with LDL and so on and so forth and all-cause mortality. Now, one thing to understand, though, is that I also gave you a question that demonstrated that low vitamin B12 levels can actually increase the rate of lipid synthesis, LDL, so on and so forth. So if you do see somebody with a good triglyceride to HDL ratio, that doesn't let them off the hook entirely if their cholesterol level is, quite high, getting in the 7s and 8s and so on and so forth. And it's worth having a look at these underlying factors, which we know can actually increase cholesterol levels. So we know, for example, an underactive thyroid, you mentioned that, an underactive thyroid is associated with increased cholesterol levels, deficiencies of what we call the methyl donor nutrients, B12, folate, betaine, choline, so on and so forth, that is associated with increased levels of cholesterol. In terms of things, we know that hemochromatosis, iron overload, is associated with hypertriglyceridemia, and even a hemochromatosis carrier state, you don't have to be homozygous. You can be heterozygous and still have borderline triglycerides. So there's a lot to dig on, but this is not a lipid shoot, so we won't do too much on that. But HbA1c is a lovely thing to do. and that's really not done often enough. But just be mindful that HbA1c has some limitations. So when we're looking at HbA1c, what is it? We've got a red blood cell, and it's got sugar attached to it, non-enzymatically attached to the red blood cell. So what two factors influence HbA1c levels? So are you able to give me one factor now that would increase somebody's HbA1c?
I mean, your concentration of red blood cells, like anemia, can change it, and then also your blood sugar levels, like your chronic.
Blood sugar is the obvious one, and you are absolutely correct about anemia. But that's more because of the lifespan of the red blood cell. So if you've got more sugar in the blood, more of it's going to attach non-enzymatically to the red blood cell. But what happens if your red blood cells are living for a lot longer? If because of a deficiency they're just not turning over, then you'll get an exaggerated HbA1c reading. What happens if you've got a lysis syndrome, hemolysis, and you've got a very short red blood cell lifespan, which, by the way, you can assess, you can get a feel for with something called reticulocytes, the new red blood cells.
Yeah.
So
that would follow then in that case. Like you get a falsely reassuring HbA1c if you've got fasting.
Exactly. So my preference is to actually throw a continuous glucose monitor on people. And with a doctor's letter, people can get you don't need to be diagnosed as type 2 diabetic. You can get one with a doctor's letter. And Freestyle or Abbott have a deal on at the moment where the first one is only $15. And I think that's an absolutely beautiful thing for most people to do. Now, you mentioned LFTs, which is absolutely 100% correct. I just want to talk briefly about the biochemistry of the LFTs. These are commonly misinterpreted. So there's two that we mainly look at. We'll just put GGT and ALP to one side, alkaline phosphatase to one side. We'll just look at AST and ALT. Now, AST is usually found in not insignificant amounts in skeletal muscle. So if you've ever got a rise in AST, that's very suggestive that there could be a muscle problem. And you'll also have a look at creatine kinase, which is another intramuscular enzyme. And you'll usually see that AST and CK levels will usually track together. ALT is much more preferential to liver itself. But understand there's two possible causes for ALT being raised. You can actually have hepatocellular damage and you'll get that enzymatic leak, which is, very predictable. But it's also an enzyme that's associated in energy, the dealing of pyruvate. And if you have an energy excess from a high carbohydrate diet, that can actually induce ALT levels to increase. So I won't bore you with the biochemical mechanisms. That just understand high ALT may be a sign of early metabolic derangement. And that's why we often see it elevated in pre-diabetes or diabetic states. It's not just hepatocellular damage. In the way that GGT is an inducible enzyme, ALT is also an inducible enzyme. You also talked about hypertension. Does this gentleman have hypertension?
It sounds like a trick question. I mean, he does in the room.
Well, it does technically. No, absolutely, he does. But I guess the question is it hypertension we should be concerned about? Does the categorization of him as hypertension, does that marry up with the science about what we should be treating? Now, I would argue that if we look at the literature on all-cause mortality, there's very little difference in all-cause mortality in a systolic blood pressure of 140 to that of 120. And especially when we look at the longer-lived populations, if we want to establish longevity, we want to look at who are living the longest. Well, the oldest people, there's no real difference in mortality with a systolic of 120 to 140. The other fact is that we're often focused heavily on pulse pressure or diastolic pressure. And to the best of my ability, when I've actually looked at the literature, the predictive value of diastolic pressure and pulse pressure is far inferior to that of systolic pressure. So for the most part, I tend to just focus on systolic blood pressure. And in terms of all-cause mortality, if I'm saying, yes, trick question. I said mild hypertension here, but certainly that's not something that I would be concerned about. I'd say, okay, 140, let's watch that one. I'm certainly not going to scare the patient and saying, we're going to put you on blood pressure medications, you're going to die, so on and so forth. And we often gaslight our patients. We see patients get scared by these kind of numbers. Statistically speaking, 140 systolic is simply not that bad. But I think the glucose of 6.9 is what mostly concerns me. Do you have any thoughts on that?
I think maybe more from this talk, but prior to today, I probably would have said no. I think it's still under the diagnostic criteria for sort of pre-diabetes or diabetes.
Yeah.
But I mean, presumably it is still higher than we'd want in the context of someone with metabolic syndrome.
Absolutely. And we know this is pre-diabetes. I mean, we can call it pre-diabetes. We even have another condition called pre-diabetes, which we can talk about the mechanism of. But basically, it's a scale, it's a continuum. We often think about these things as dichotomous variables. It's either good or it's bad. I mean, these reference intervals really lend themselves to that. You're in or you're out. But if we actually look at the data, they're on a continuum. And this guy is certainly headed for bad health. And of his cardiovascular risk factors, the elevated glucose really stands out to me. And I would actually argue that somebody with pre-diabetes probably should be given exactly the same lifestyle interventions as somebody with diabetes. Now, here's an interesting question, and you may not know the answer, and if there's anybody else who wants to chip in, it's what is the underlying pathophysiological cause or the likely pathophysiological cause of his glucose being slightly elevated at 6.9?
I would have thought it would be more of a type 2 diabetes pathway, so sort of burning out of the insulin-producing cells in the pancreas, but be my thought.
Right, so
is it due to insulin insensitivity?
Exactly, insulin resistance. So the insulin this gentleman has is in all likelihood not working properly. But that's not the full story, because we know that in about 10 to 15% of adults diagnosed with type 2 diabetes, they actually have an autoimmune form. We can call it latent autoimmune diabetes of adulthood. And you have a combination of insulin not working properly, that's the insulin resistance, combined with an insulin deficiency problem. And that's what you just referred to when you said the pancreas, the beta islet cells in the pancreas burning out. So this is almost certainly an insulin resistant problem. But we do need to try and get a feel for, well, is it possible that he could be one of these 10 or 15% who's, failing to produce enough insulin, because they need to be managed differently. If your insulin's not working properly, lifestyle management, such as an appropriate reduced low carbohydrate diet, exercise, so on and so forth, can be absolutely fabulous. But if you're deficient in insulin and you've tried everything lifestyle and you've maxed that out and your sugar's still high, then you need to replace that insulin. There's no other two ways about it. And the best way to do this is with a modified oral glucose tolerance test. So we give people, they have the 75 grams of glucose and we measure their sugar level. And at the same time, we measure their insulin level. Because if we see that somebody in a type 2 diabetic, we'll see the insulin level will be really high. Their pancreas is releasing the insulin, but it's just not doing its job. But if you're going into this LADA, latent autoimmune diabetes of adulthood, you'll start to see the pancreas starting to fail. The insulin is actually inappropriately low. So it's very important to try and get a feel for those two different cases there. So one of them, insulin's not working. The other one is you just don't have enough insulin. And this oral glucose tolerance test with insulin, it can be done, you can order it if you want, is the most effective way of assessing for a deficient insulin secretion. Now, just as an aside, we mentioned blood pressure earlier, and you sort of mentioned, or you alluded to essential hypertension, which is just blood pressure that occurs. In actual fact, it's the action of insulin, usually in a hyperinsulinemic state on the kidneys, that drives essential hypertension. And nephrology doctors understand this very well. So you're probably familiar with the epithelial sodium channel, the ENaC channel, in the kidneys that actually retain sodium. So this is what aldosterone acts on. Well, insulin activates the same transporter. So we know that basically if you've got excess insulin acting on the kidneys, that leads to excess sodium retention. It's the sodium retention that drives the blood pressure. So if you've got somebody, so if he's a bit mild hypertension, let's not start this chap on drugs. Let's have a look at his insulin and try and deal with his insulin resistance. And the fact that he's on a standard Australian diet really tells us he's probably on a crappy diet. His, the standard Australian diet is a very, very low bar. Now, I'm not sure that we've got a lot else. You also mentioned thyroid testing. I'm not sure that, obviously thyroid can affect your lipids. Interestingly, it is often overlooked, is with an underactive thyroid, that will actually lower your blood pressure. So this is particularly common in females. We might be having them come in and their blood pressure might be 110 systolic or even 100 systolic. And we often write it off because we've been led to believe that low blood pressure is always better. And that's simply not the case. And it's often that you have subclinical hypothyroidism or even, florid hypothyroidism. And often I'll only pick that up when I take their blood pressure and say, well, your blood pressure is quite low. And we do further investigation and we'll discover that. One other point that I think we should talk about, we talked about ketoacidosis and understanding the difference between ketoacidosis and nutritional ketosis. And we said that insulin is the key. Now, because 10 or 15% of people with type 2 diabetes may actually have low insulin levels, they might be at increased risk of ketoacidosis. And you've probably heard there's this class of diabetic drug called the SGLT2 drugs, which are associated with ketoacidosis. In actual fact, the literature is very clear that when we look at those case studies, we only really ever see that they cause ketoacidosis in people with insulin deficiency. So if you're going to medicate for diabetes, or if somebody's on one of these drugs, the SGLT2 inhibitors, then you really should be at least doing a fasting insulin to make sure they're not insulin deficient. What about
Sorry,
yes.
can I ask a question just about the lipid studies? I know this isn't a lipid shoot, but you were talking about Emma was talking about sending off fasting lipids, and you were talking about HDL, LDL ratio. What's your 2 cents on apolipoprotein B, and would you routinely send it off for patients like this?
This is a little complex. So the thing is, apolipoprotein B, there's only one of them on the lipoprotein. And you have to understand what this actually measures. So when lipids get synthesized by the liver, we've got the class very low density lipoprotein, VLDL. As that circulates and that donates its cargo, it actually shrinks a little bit. It becomes an intermediate density lipoprotein. Then it donates a bit more cargo and it becomes a low density lipoprotein. So we've got these 3 particles that we talk about in medicine as though they're 3 different entities, but they're really like a deflating balloon. They're exactly the same thing. It's just lost a bit of content, lost a little bit of air. And each of those 3 particles actually contains the ApoB100 moiety embedded within the membrane. So when we're measuring an absolute ApoB100, we're not always sure which one of these we're measuring. And it is significant because LDL is actually, we know the association of that with health is that it's actually probably better higher. Whereas VLDL, which is really how we assess triglyceride level, that we don't actually directly measure triglycerides, we just calculate it based on VLDL level. VLDL production, which is driven by lipogenesis, we know is actually associated with poor health. So there are some limitations, and you have to understand the underlying biochemistry and the physiology of how these lipids are generated. In general, its ratios are better. So I certainly wouldn't look at ApoB100 in isolation. But I generally feel if you're looking at a HDL to an ApoB ratio, that would be better, or a triglyceride to HDL ratio. But understand that when you're looking at B100 levels full stop, you don't really know everything that's making it up. You can measure it, by the way. You can do something called a lipid electrophoresis, but that's over $100, and you probably want to know how to interpret that before you order it.
Great, thank you.
Sorry, I know that's possibly not an overly helpful answer, but there is a bit of nuance to that. Well, I think in the interest of time, we better move on. So thank you so much.